Good afternoon, everyone, and welcome to our third webinar to support our methods and processes and topic selection consultation for health technology evaluation at NICE. My name is Jen Prescott. I'm a Programme Director in the Centre for Health Technology Evaluation at NICE, and I'm responsible for process and operations for our health technology evaluation programmes. I'll be chairing the webinar session today for you, and I'm also joined by 6 panellists to discuss some of the proposals we're making to support your understanding of the consultation and the documents we've provided. We have a larger panel than we've had on other webinars, but hopefully that reflects the breadth and depth of the topic selection and process proposals we'll be discussing today. This webinar will be recorded, and we'll be having a Q&A session at the end of the presentation that some of our guest speakers will do for you today. In this webinar today, we are going to cover aspects of the topic selection process and proposals for changes to the guidance development processes. We won't be covering the highly specialised technologies criteria today, nor methods related conversations, and I would direct you to the other webinars that are focusing on those areas at your own leisure. So let's move on to the first slide. So NICE plays a critical role in the healthcare system in the United Kingdom. The work that we do is vital in ensuring rapid access to both clinically and value for money technologies. We want to benefit patients, the NHS and life sciences. We need to ensure that evolving and improving our methods and processes ensures that we as NICE adapt to emerging changes in healthcare and health technologies within it. Our overarching goal is to improve the health of people using the NHS and social care systems, and in doing so, to support equitable access for people using the NHS. In our consultation proposals, we've outlined 5 reasons for the changes that we're proposing to make in how we both assess and appraise health technologies. The first is a recognition that as health technologies rapidly advance, so too do the methods and processes of evaluation, and therefore the need for effective selection of new and important technologies is incredibly important. The second is that reviewing our methods and processes allow us to remain agile and also responsive to support rapid access to new technologies that are clinically effective and value for money. Our methods and processes underpin robust, consistent and transparent decision-making by our committees that need to evolve, as well as societal preferences also change. There's a greater need for alignment between the work of regulators, assessors and payers in the United Kingdom to create an ever more receptive environment for new, emerging and innovative health technologies. And finally, the 5th area was that COVID-19 has put a spotlight on the importance of medical technologies such as diagnostics, devices and new digital technology. And these methods and processes allow us to level up how we select and how we manage these exciting new technologies and their introduction into the NHS. You'll find that through all of our proposals, there's really clear benefits for patients, for faster access to innovative health technologies and an easier way, hopefully, to understand and contribute to our evaluations. For the life sciences industry, they will find a responsive, flexible and predictable way of working with NICE. And of course, they will also see flexibility when the evidence we find is difficult to analyse and interpret. Through the proposals, we offer broader support for a comprehensive evidence base, including real-world evidence. And then finally, for the NHS, our proposals, we believe, will ensure a fair, equitable and evidence-based access for innovations. And of course, in the end, as I've mentioned previously, it's important for NICE to ensure that technologies that are clinically effective and value for money will be supported through our new proposals. We're confident that these new methods, processes and topic selection changes will support the ambition that has been formally laid out in the New Life Sciences Vision to make the UK the best place to discover, develop, test, trial, launch and adopt new technologies. So this webinar is focusing on topic selection and processes. We've already held a webinar on methods, and hopefully some of you took part in that webinar. We've also held a webinar on highly specialised technologies, selection and routing criteria, and hopefully some of you also took part in that webinar also. There's another webinar planned to take place tomorrow, and I'll give you some more information on that later on in the session. But just to introduce the panelists and the speakers we have today, we have Laurie Farrar, Associate Director for Horizon Scanning and Topic Selection, Lee Dobson, a Programme Manager in our Medical Technologies Evaluation Programme, Mark Rasburn, a Public Involvement Advisor, and Jenna Dilks, an Associate Director for Planning and Operations. And they will all be talking you through the proposals that we'll be making in our topic selection update. After their presentations, I'll be coming back with a couple of additional guests, Paul Dimmock, a Technical Advisor, and David Thompson, an Associate Director within our Commercial Liaison function. And I will be hosting a Q&A session with all panellists. So please do, as we're moving through the presentation, if you have any questions, please do start to filter those through in advance of starting the Q&A session. So over to Laurie first.
Thanks, Jen, and good afternoon, everyone. So I will take you through the overview of the topic selection proposals that's been part of this consultation. So first up, I'm going to give you a snapshot of what we're going to cover today. Number one, the topic selection manual, the criteria for identifying, selecting and routing topics. Within that is also the eligibility criteria that we received a fair amount of comments from the consultation that took place in the autumn last year. The creation and membership of the topic selection oversight panel, known as the TSOP. And lastly, the transparency of decision making, publishing the topic selection decisions and the challenge process. So first off, the topic selection manual. Sorry, next, thank you. So you can see on the left-hand side here that the manual covers in detail these areas of the identification of topics, the eligibility and selection criteria, the routing considerations, topic briefings, the TSOP panel again, and communicating selection and routing decisions, and timings and engagement of the process as a whole that has been missing and was a requirement from stakeholders. So on the right-hand side of the slide here, we've just got four snapshot boxes that kind of really hones into what the four key areas that came out of the consultation that held in the autumn last year. And that was clarity on the types of health technologies that are appropriate for evaluation, more questions about the panel and how they select the topics, and proposed refined criteria on for the highly specialised technologies evaluation programme. But as Jen has said in her introduction, the webinar on the refined routing criteria for that programme was presented last week. So if you missed it, you can look at the nice YouTube channel to look at that. And then lastly, clearer communication of selection and routing decisions, and how in exceptional circumstances a routing decision can be challenged. Next slide, please. So firstly, I'm going to go through the criteria for identifying, selecting and routing topics. Next slide, please. Thank you. So here is, this covers two slides, this part about the eligibility criteria. And a lot of the comments that we received from the consultation last year is that the criteria were not clear and that you needed more examples. So through this consultation, we've tried to add a little bit more detail and make these a bit more clearer for stakeholders to understand. So for devices, we've added examples, and these are the highlighted yellow sections of the table. So we've said that this includes wound dressings, catheters, implantic, neuromodulators, and apps or software used to deliver cognitive behaviour therapy through a smartphone. And then for diagnostics, you can see that there's quite a long list there as well. Now, I'm not going to go through those, mostly because I think I'll trip myself up with the explanation of some of those later on, but you can see them for yourself there on the screen. And now you'll see that for medicines, there are no examples. There was a requirement, or a request, sorry, that stakeholders asked us to be more clearer on what was meant by a new active substance or a significant license extension. Now, these terms came from the 2019 voluntary scheme, so they're a little bit harder to give examples of. But as I've mentioned in various forums with stakeholders, and you'll see later on through my presentation, that topic selection are working to be more transparent with their decision making. So examples of these will become clearer when we explain our decision making on the NICE website as we work through these. But for a general rule for license extensions that is not considered significant, that will be something that may be covered by a commissioning policy that's available. For example, the Medicines for Children policy, whereby a paediatric license extension comes into play. Next slide, please. So again, here, the yellow parts show the changes that have been added. So the interventional procedures, we have added examples to the manual of what these may be. And then we've also added 2 new areas on the left-hand side, the combination or integrated topics and other topics that have direct patient benefits. And then you can see on the right-hand side that we've added examples to the manual of what the eligibility may be to be considered as part of the topic selection process. Again, I'm not going to go through them because they're quite wordy, and you can see on the slide there for yourself. Next slide, please. For this slide, I just wanted to really try and show to stakeholders what we actually mean in topic selection by selection and routing. So the selection criteria is where a technology has been identified as eligible, and that must then be considered and assessed against the selection criteria. So they almost kind of go through 3 hoops, if you like. So you've got the eligibility, and then is it of value to the NHS for NICE to look at this? What should it be selected to progress for NICE guidance? Each type of technology has different selection criteria, and all of that is clearly laid out in the manual. And then you've got routing. So once we've considered its eligibility, we've decided that absolutely there is value in NICE producing guidance for this, it should be selected. Now is the appropriate route, as in which guidance product does it go to? So as you can see on the bottom there, we've got diagnostics, highly specialized technologies, interventional procedures, medical technologies, and technology appraisals. And that there is the role of the topic selection oversight panel. They look more at the routing, and in some cases they look at the selection as well, where there are some topics that are not as clear cut as to whether they should be selected or not. Next slide, please. So now I'm going to talk about the creation and the membership of the Topic Selection Oversight Panel, the TSOP. So in the autumn last year, when we did our consultation, you will see that we proposed here about the TSOP and its creation. And it was actually already signed off by the board pre-consultation for us to implement this. So this was implemented in July last year. And has kind of been going on for a year now. It's had quite a few changes, but we're changing it all the time. We're taking quite an agile approach. But the biggest introduction and the change since last year is the purple box on the screen there, where it says lay member ×2. So we have now recruited and have 2 active lay members on the panel, and they're already up to speed and providing real value to the discussions that go on in the panel. And the rest there, you can read those for yourselves on the screen. And as part of the consultation, we have also updated the terms of reference as part of the consultation, so that you can see how that panel will work. There was also a request in the consultation last year about the inclusion of patient groups and industry representatives. We feel that the introduction of the lay members are the patient voice, so therefore there is no need to align the topic selection oversight panel with the committees and having that. And then also the industry members, we felt that this conflicted with NICE's social value judgments on 3.2 inclusivity, and we also feel that there are other forums that incorporate the views of industry bodies, such as the Accelerated Access Collaborative, which exists to streamline the adoption of new innovations in healthcare, and we did not feel that their membership was appropriate on the topic selection oversight panel. Next slide, please. So transparency of decision making, publishing topic selection decisions, and the challenge process. So those of you that was in the webinar in the autumn that we did for the proposals last year, you'll see that you'll remember that I did a poll as part of that webinar to ask you how you felt about the topic selection decisions, and did you agree with transparency and how you would like to see it. So as you can see on this slide, there are variances across our centre. So for technology appraisals and highly specialised technologies, we have that really cumbersome spreadsheet that is really difficult to be able to find things. The medical technologies evaluation program have a Word document that is just a list, slightly easier to find perhaps than the TA-HST version. And then IP have a really nice web page. So what we've tried to do is we've tried to encompass all of the information across those programs and work as to what would work for stakeholders. So if we go to the next slide, please. Might just be frozen. There you go. So next step. So what we're trying, this is not absolutely what it will look like. We are still working with the developers, but we are hoping that from January 2022, we will be able to have better showing of our decisions on the website. So as you see here, that there will be a single topic selection web page, which will have three key headings, and that's the decision, the reason for the decision, and the date. So this will solely be for topics that are not selected. So that way stakeholders will be able to easily search on the NICE web page. So if you put in a drug name, for example, on the NICE web page, it will direct you to the topic selection web page, and you can see all of the information there. That is something that the medical technologies Word document and the TA-HST spreadsheet won't allow you to. You have to go and dig to find that information. And then on the right hand side, you will see an actual topic web page. So when a topic is selected, the topic web page will be created really early at that topic selection decision. It will have all the selection information, the routing information, and we should be able to update as we can with the most up-to-date scheduling information as well. So there's a lot of collaboration going on between topic selection, the scoping team, and the scheduling team as well, to be able to provide stakeholders with that clear, up-to-date and transparent information on a topic in the NICE process. Next slide, please. So challenging a routing decision. So this is something that we have gone through, or we do go through, I should say, in the process, but it's not something that's been overly advertised. So this is on the routing decision that we can receive a challenge. So you can see here that a company or another stakeholder can seek to challenge the routing decision. They must submit rationale for the reconsideration to NICE at the topic selection email address that's there within 14 days of the notification of the decision. Now within that, we want new detail or new data, I should say, that will consider to change the panel's mind. We don't need a representation of stuff that has been considered and discussed during the scoping phase. The challenge is then reviewed by NICE and the panel, and then if it's applicable, we will take that for ratification to the NICE executive team. Following that, the company is notified of the outcome of the reconsideration, the rationales provided, and the information will be published on the NICE website so that stakeholders can clearly see what's happened in that process. And once that's happened, there is no further challenge. That decision is then final. Again, everything is in this consultation document for you review and to comment for as part of the consultation. And then I think that is my last slide for today. So I will hand over to my colleague Lee Dobson to go through the process elements with you. Thank you.
Thank you, Laurie. Thank you very much. Hi. This afternoon, I'd just like to talk about the overview of the proposals that we have in the process part of the consultation. Many of you will remember that back at the beginning of the year, we went out for a principals consultation, and these proposals are really based upon the consultation comments we received as part of that consultation, and we really have built upon the feedback that you all gave us in order to help us improve our processes. In the next slide, I just want to explain the 3 areas that we've covered as part of our process consultation. So the first of those is alignment. What NICE has tried to do here and has been working on for the last couple of years is actually create an aligned, unified process for all of our technology guidance on pharmaceuticals, highly specialized technologies, devices, digital technologies, and diagnostics. So ideally we have one process that all our stakeholders use and engage with. And part of that is to try and create, learn from all the best practice in these different programs, and trying to create the best process that we can. Currently, our stakeholders have different experiences and have different rights and abilities in these different programs, and we want to really create a single unified experience for our stakeholders, which will hopefully make a clear process for them as well. And it will also be efficient for both NICE and allow us to use those resources to help develop this process a lot faster in future. One of the other areas we've focused on are new ways of working, not just about alignment, but how we can improve the process, how we can make it faster, how we can make sure we reach decisions in the best way, and create the systems in place that allows us to do that. And lastly, we've also looked at our commercial and managed access processes, looking how we can ensure that we have a good process in place to come to good commercial decisions and get best value for money for the NHS, and also have a process to get access to patients for technologies where the evidence base isn't yet strong enough to give a clear yes on that technology. So if we can just start by looking at alignment. When we went out for the principals consultation, most of the proposals that were in there were very positively received and very strongly supported by all the consultees, which was really good for us. Those that where there wasn't strong support or there were questions, we actually sort of engaged with our stakeholders in this period, tried to often explain in a bit more detail what we were trying to do, and we've basically gone out and listened. One of the key things that was raised was for our guidance for medicines, we couldn't have an option to go from the first committee meeting straight to final guidance without a second committee meeting, without a consultation. And we proposed to extend that to devices and diagnostics guidance and digital health. But it was clear from the consultation that we didn't really explain when we would use that. So we have gone out and talked to our stakeholders. We have explained that we will be using that only where the guidance is positive and stakeholders are in broad agreement with that guidance. And we've also sort of piloted that scenario on our first piece of medical technologies guidance, which is for a technology called Plus Sutures. So we have gone out and explained that in a lot more detail, and that still remains within the consultation as well. So we have gone ahead with that. Some of the other proposals that we had on alignment, one of the key things in the next slide is about terminology. So a lot of our stakeholders will be involved in guidance for pharmaceuticals or for devices or for diagnostics, and we want to make sure that we as NICE actually use the same language in all those processes. They all have the same steps and stages, and our organisations can all interact in the same way, and whether they're involved in a guidance for pharmaceutical or a diagnostic, their involvement is broadly the same, and it's very easy for them to engage with us and help us develop the right guidance. So we've used common terminology across all the programmes. One of the other proposals we had was that the guidance consultation, when we have a consultation, may in some cases be less than 28 calendar days. But we did get a lot of feedback from our stakeholder groups that they definitely needed that time, and they wanted that time to make sure that they could fully be able to comment on our guidance. So we have retained that at 28 calendar days, which is what it currently is. The one thing we have added in there, which we've again taken from one of our pharmaceuticals programme, is that the first 7 days of that 28 days, the draft guidance will be with the main registered stakeholders in the evaluation before it goes public. And that allows them just to prepare for when the draft guidance does go public and prepare their sort of stakeholders and organisations for that going live. One of the other areas where we have tried to bring together the process is the appeals process, which currently happens in technology appraisals and HST, and the resolution process, which is the similar process that happens for medical technologies guidance and diagnostics guidance. So both of them now have a factual error checking stage, and then the appeal and resolution is broadly similar as well. So we've kind of made all the stages very similar. One of the other areas that we've also looked to align is for our professional organisations, that in all of our guidance programmes, they can provide written submissions of evidence. That currently doesn't happen in every programme. So we've brought that in as well to make sure that each stakeholder basically can provide evidence in all of the programmes that they want to be stakeholders in, and obviously we want that evidence and to actually value that. I think next I'm going to hand over to Mark Rasberg. Mark.
Yeah, thanks, Lee. So the changes we're speaking about today will have an impact on all of our stakeholders, such as aligning terminology, as Lee's just mentioned. But we wanted to highlight a few changes that improve our patient and public involvement. So on this slide, we've picked out a few of the key changes in the manual that we feel will improve our patient and public involvement offer. The first change is the introduction of patient experts providing patient evidence across all of our programmes. So for those who have been involved in our technology appraisals or a highly specialised technology appraisal, this is something you'll already be aware of. But we wanted to extend this practice across all of our non-medicines programmes, so we're able to kind of standardise best practice and increase the patient voice throughout all of our work programmes. The second change is the introduction of the summary of information for patients. So this is something that was actually pioneered by our colleagues over at the Scottish Medicines Consortium, and it has been a voluntary option at NICE over the past 12 months, which some companies have volunteered to help pilot. So it might not be something that you're unfamiliar with, but its purpose is to help patients understand industry submissions so that they can better engage in the appraisal. So it's essentially a plain English summary. And the benefits of this summary is that it provides a better understanding of the evidence, which makes it easier for patient organisations and patient evidence to write evidence submissions. It helps with the technical engagement and involvement at committee meetings. And there is a summary, the summary is on a template which we provide, and there are guides to companies and guides for patient organisations to help them get familiar with the process and what it actually looks like. The third change on the slide is extending our written submissions across all HTA programmes. So similar to patient experts, written submissions were already in place for most of our programmes, but we're expanding this to our diagnostics programme to again standardise our patient and public involvement approaches. The fourth change is the move to virtual meetings. So in the manual, we propose committee meetings are primarily held virtually and usually open to members of the public and stakeholders. And we feel this change will support our commitment to openness and transparency, as it enables stakeholders and the public to see firsthand how the evidence is evaluated and interpreted, the decision-making processes which happen at the committee meetings, and how the consultation comments are taken into account. Now, we first introduced this practice as a necessity due to the lockdown measures early last year, but we found that it enables greater patient involvement of those who may not have been able to attend our face-to-face meetings. So for reasons like health reasons, work reasons, or caring responsibilities, which may have restricted their ability to travel to one of our offices. It also increases public attendance, so we're able to cater for more observers, and in the same way to committee members and patient experts, it reduces the need to travel to meetings. And in one of our committee meetings, we actually had over 90 public attendees, which is something we wouldn't have been able to accommodate for had we been meeting in a physical space. Now, we are aware we're still learning about virtual meetings, so we're constantly reviewing and learning best practice for these meetings. But the initial evaluation across all of NICE's programmes, it shows it has had a positive impact, and it has shown to have benefits to our patient and public contributors, and I'm sure most of all the stakeholders. The fifth item we've listed is a running theme throughout the manual, and that's the support offered by the Public Involvement Programme, and this is for patient organisations and patient experts. The first big change is that we've introduced monthly meetings with patient stakeholders, and these meetings are designed to talk through the HTA process, the support available, what information the committee needs, share best practice of how they can strengthen their impact, and answer any questions that organisations may have. We're also offering patient stakeholder feedback, on their participation. So this is a process to systematically collect feedback from committee members about the impact of patient evidence. And this information is then shared with the patient stakeholder to let them know what the committee found helpful and how it actually influenced the decision. So not only does this help to increase the transparency of the decision making, it can also help identify what information the committee require to improve future submissions. And the last thing we wanted to highlight is that we're extending our exit survey. So where previously we routinely asked individual patient experts about their experience on the appraisals once it had ended, we've now developed a survey for organisations, and this is to help us to formally monitor their experience, identify any successes they've had, along with any issues, and that will help my team to continuously review the patient and public involvement offer that NICE provides to ensure we're able to adapt and support organisations where necessary. I will now hand over to Jenna. Next slide. Thank you.
Thank you, Mark. So I will be taking you through a few more slides, focusing again on those new ways of working that Lee mentioned earlier, and also on commercial and managed access. So looking at the new ways of working proposals that we made in the first consultation, we received lots of comments, and some of the main issues raised were around our proposals on the removal of the technical engagement process, which was part of our process that we introduced in 2018. In the proposal we made in managing company submissions with significant base case incremental cost effective ratios, and that was a proposal where we would potentially pause after company submission if we identified that significantly higher ISA to enable discussion. And also on our proposal for the removal of fast track appraisal processes for low ISAs. So our responses to the comments that we received, we have not continued with the proposal to remove technical engagement, but what we have said is that technical engagement should no longer be a mandatory stage of the process, and instead we have described how it can be used as an adaptive step, so flexibly to enable us to still unlock those key challenges ahead of committee where required, but where we could perhaps flexibly adapt our process and perhaps not use technical engagement where we've identified it would be appropriate. We have also continued with the proposal to remove the individual process for highly cost-effective technologies, but have retained and described incentives for using this approach within the standard process. So we will continue that proposal to remove that option, but like I said, we will still, if we are approached with that flexibility, we will look at our standard process and use it adaptively when we've been approached with that proposal. We're also going to rename the remaining fast track appraisal approach to cost comparison, just to more accurately reflect what it now is. Next slide, please. So just wanted to highlight that when we were considering new ways of working and the process proposal that we were making, we really had to consider the key process elements: speed, cost, dependability, flexibility, and quality. So in any process, if you're focusing on one area, for example, if you focus on the speed of your process, there is that risk that you're going to affect your ability to be flexible, or perhaps the quality of your process. Or if you're focusing highly on the quality of your process, you're going to affect your ability to be speedy or to be flexible with that. And we need to really consider all these elements and make sure that it was critical to build and document a process that's rigorous enough for clarity, yet flexible enough for a range of responses. And this is a quote that's taken from our chairman, Shah. We're really aware of that, managing that tension regarding speed versus inclusion, engagement, and robustness. And we heard this quite clearly from industry, that whilst they really do think we're already quite fast, if we focused on speeding up and getting ever quicker, they were concerned that we would compromise that robustness and integrity and the quality of our work. And their preference was to manage optimal appraisal timing. So that's working with industry to recognise those optimal submission timings. We have to really think about flexibility and what that actually means for us. I just wanted to focus in on that word and say that when we say flexibility, we don't mean creating a bespoke process for all the types of technologies and all the topics that we look at. In fact, doing that is not efficient at all and does lead to a reduction in productivity. Instead, we wanted to think about that targeted flexibility. So perhaps imagine that 80-20 rule, and the idea that 80% of the topics that we look at would follow that standard, that dependable process, but 20% we could afford that flexibility, adaptability where required and where it's identified as necessary. So while we've been looking at all these key process changes and proposals and thinking about these different elements, the idea is to think about where we can most correctly apply the flexibilities and using those approaches like retaining current timescales of consultation, but perhaps adapting them where necessary. So using that standard process flexibly. Next slide, please. There are some other process review proposals that we made. Technical engagement used across all programmes, including HST. So I did mention earlier that we would continue with technical engagement. We're not going to remove that, but it would be an optional step, not mandatory, and now across all programmes. The consideration of not using a committee meeting to make a recommendation in the fast track appraisal process, like I mentioned earlier, that's now going to be called the cost comparison process. Managing company submissions, again mentioned earlier, when the company-based case ISA is significantly higher than the threshold. We also encourage utilisation of the multiple HST process. We are going to continue to include this as an option. We don't expect to see this process very often. We think it will be used rarely, but it is good for us to have that as an option. Perhaps in the area of reviews, when we are reviewing our HSTs and we have similar products, and where that would create efficiency for us. The explanation of use of treatment eligibility criteria used by NHS England Improvement. We have also maintained our ability to route directly to clinical guidelines. We still think there's a case to be made for this process, so we will still have that option to route through to our clinical guidelines programme. Earlier and wider identification of patient and clinical experts. So we want to make sure that we're doing the most we can to have the appropriate engagement and input from patient and clinical experts. So we're going to make sure that we look across from scoping through to appraisal for our experts, if appropriate, and also if we're struggling to find experts, post-patient and clinical experts, we'll then look wider across the institute and look at what other programmes have done, who they've used, what knowledge they've managed to access, and whether that would be appropriate for us to engage with as well. We include a new process for reviewing biosimilars due to loss of market exclusivity, and where the originator intervention and perhaps was a negative recommendation, and it's possible that doing that rapid review of the biosimilar may result in a positive recommendation. And also terminating MTEP topics where a company submission has not been received. So similar to how we work now in technology appraisals, we feel we should really be able to draw a line under that. When we haven't received a company submission for an MTEP topic, we should be able to terminate and publish that. Next slide, please. So the final key theme for process review that I wanted to go over was commercial and managed access. So we had a really overall positive response to our recommendations, which is great, in our proposals. But some of the issues raised were we had a request to formally extend these processes from pharmaceuticals, but also to include devices, diagnostics and digital technologies. We had a rather mixed bag of responses regarding a proposal to have delay and be flexible regarding the budget impact test. So this is a proposal to perhaps pause the publication of the FAD, the draft final guidance, if there are budget impact test issues to work through. And there was some concern on the idea of scoping topics at guidance review. So these would be topics which have been through managed access, and we propose that we may want to rescope before we start the review of these topics. So what was our response? Well, we have developed an aligned single approach to guidance reviews that balances our desire for flexibility, but manages the changes to treatment pathways post-data collection process. We've confirmed where flexibility might be applied post first committee meeting, so that's with the pause if we're considering budget impact test issues, but also to allow for other commercial discussions. And we've added detail on the entry criteria and the process for assessing proposals for managed access. including those opportunities for devices, diagnostic and digital products. And I just wanted to highlight that we have been very careful to be very technology agnostic with our descriptive wording in the manual for commercial managed access to make sure we have that flexibility and that adaptability programs. Next slide, please. And the final slide for me today is just to highlight that there are still a couple of issues that couldn't be resolved in time for this unified manual, but that we will still be working on. So these are the proposals for straight to managed access process. So instead of having to go through the, the standard process, being able to move straight through to managed access. And also a proposal on how to manage technologies with multiple indications, for example, the immuno-oncology drugs. Both of these proposals are very complex. They require some complex discussions and quite complex solutions. And we need to make sure that we're engaging fully with the stakeholders and we have significant buy-in, and we've managed to look through and manage all the risks that may be associated. So these two proposals will be the subject of our first modular update, developed over autumn and winter this year, with the idea that we aim for publication in 2022. Thank you.
Okay, thank you to all of the speakers in the webinar so far today. And we have some time for a Q&A session, although unfortunately time is running rather short. But the team have been working very busily in the background, I think, answering some questions in written format. So that's great to see. But we do have time to answer some more questions. So if I just ask the panelists just to pop their cameras back on, just so that you're ready to go. Should I target you with a question? Okay, maybe if we just go right back to the beginning, and Laurie, thinking about topic selection, we've received a question just asking about the challenge route. Is how would a challenger or a stakeholder know what was considered at the topic selection oversight panel in order to provide new evidence if they would wish to challenge a decision?
Well, I guess this is a good question, and maybe I wasn't quite clear on who can challenge. So the challenger would be the company or the person that has suggested, meaning the stakeholder that has suggested the topic. So it's not just companies that we liaise with and that we consider topics by. So they would have direct contact with the topic selection team who have regular communication on what's happening with the topic and the outcome. So you would know through direct communication.
Okay, thank you, Laurie. Lee, there's a couple of related questions in terms of some potential new additions for the medical technologies programme. I think this is in question to the inclusion of there's a pathways lead in the manual, an adoption lead in the manual as well, and adoption support resources. Can you confirm if they're new additions from a programme perspective?
Thanks, Jen. No, they're not actually. I think we're just making available to all the programmes sort of the resources that they're using now. So often for medical technologies guidance and diagnostic guidance, we do often have additional adoption resources that are in there to help sort of trusts or whichever is the clinical organisation using that technology adopt it. They're often sort of not needed as much for pharmaceuticals, but those resources are always there available. And the pathways lead are normally involved in ensuring that any guidance that's published is linked in with our pathways as well. So it's just creating the same options for all the programmes, not necessarily adding specifically to the programmes.
Okay, thank you, Lee. Jenna, a question for you. Will products exiting managed access now go through a full reappraisal, including rescoping? Assume this might link into the current Cancer Drugs Fund review process that we have versus the managed access review process we have for highly specialised technologies.
So you may wish to help me with this, Jen, hopefully if I'm getting this correct, but I believe that we are considering this approach and this process at the moment, and we'll be providing an update on that in due time.
Yeah, absolutely, Jenna. I think it's about the key here is that alignment and consistency piece, so we have a single process for reviewing managed access products. Mark, there's been a question about PIP support for organisations that might wish to influence the data or outcomes selected for managed access agreements? Are lay members trained in how to have meaningful input into this?
Yeah, so part of my team's work is we have public involvement advisors who are assigned for each topic. So they provide kind of the advice and support for all of our lay members across the board at NICE. So specifically for health technology assessments, they'll have an assigned advisor whose job is to make sure they're able to kind of participate in all the work, be able to understand what the documents mean, where they can have an impact on the committees, on the managed access, and identify if there's any issues or barriers to involvement and address those. So simply, yes, there's that support and that designated person who can provide that tailored support, whether they need a lot of support or very minimal, we are able to kind of provide that.
Great, thank you, Mark. Laurie, a question about charging, actually. We've had a webinar attendee ask, are NICE planning to increase the charging fee if technical engagement is utilised in the medicines evaluation process?
So at the moment, the charges for all TA HST evaluations are as per on the website, and there is at the moment no aim to change those charges. But when we do a charging review in the next year or so, that may result in a change to the charge, but I cannot confirm or clarify if that will happen and what that may be at this stage. So at the moment, there is no changes to any of the charges, but please do look out for further information or consultations as we go for a charging review.
Thanks, Laurie. And just in reference to the medical technologies programme, there isn't a current charge, is there, for companies progressing through that?
No, there's not. No, the charging only applies to technology appraisals, guidance, and highly specialised technologies guidance.
David and Jenna, I was hoping I could approach you both with this question. Maybe David with your commercial perspective and Jenna with your process perspective. But could you provide more details on how the optional technical engagement could work, and when will it be decided if to use it and what terms?
Shall I kick off?
Maybe, yeah, go. Sorry, I didn't say who to go first. Sorry, Jenna, you go first and then David, please.
No problem. So, of course, probably I should have stated that when we're considering perhaps making it technical engagement optional or not using it within a process, we would always discuss this initially with the relevant company that's involved. We would always make this a decision that we've made in discussion and making sure that we're communicating appropriately. So it will be something that will be decided when it's been identified as appropriate and when we've had these discussions in advance as well.
And with a commercial hat on, Jen, I think we are exploring how we may use technical engagement where to help manage the uncertainties commercially or through managed access earlier and spark some of those conversations earlier. You'll see from the process guide around commercial managed access, we're pushing to get conversations and decisions happening a bit earlier in the process rather than after committee, although potentially allowing some time after committee for I's to be dotted and T's to be crossed. So I think there will be a commercial and managed access element to the decision as to whether to go to technical engagement. I'm assuming, however, and Jen, you may be more appropriate to comment on this, there may also be decisions made on the basis of the data being presented and uncertainties and trying to get better hold on that data, get improved data in before we go to committee.
Okay, thank you, David. Lee, a question for you maybe. We've had a couple of these as well, similar theme. Will the modular updates be subject to further consultation?
Yeah, Jen, I think there was so much for us that we could possibly have covered in the consultation. We couldn't obviously include everything. So I think we don't plan to update the process and methods manual as a whole next time, but come along with these modular updates. And I think we'll be coming out to consultation and engagement with our stakeholders as well to make sure we can get those modular updates right as well. So there will be further engagement even after this particular manual is published.
Thank you. And Jenna, sorry to target you with another question. Process is so wide-ranging, isn't it? Could you explain how NICE is working to align timelines with Project Orbis and what new ways of working might be introduced to support this. And Laurie, if you also want to come in on this as well from a topic selection point of view as well. So Jennifer, please.
Absolutely. So we do have engagement with system partners regarding Project Orbis. So we are always in discussion with the MHRA, but also with NHS England and with our partners at the SMC in discussion, you know, and we're making sure that we're speaking to companies and asking for early engagement from them. We really, you know, want to hear from them on their plans and make sure they contact us early with any changes or information that they can provide us. We're assessing whenever we're made aware of potential Project Orbis topics confirmed, or, you know, even in advance of application. We're assessing the current schedule that we have against expected marketing authorisation to make sure that we're as quick as we can be. We're speaking to companies if we feel there's maybe some flexibilities that we can make to make their processes slightly quicker. So like we've discussed today, there's adaptability of our processes and managing that in the best way in agreement with companies if we feel that we could perhaps speed up the process. But we're also discussing with NHS England when there perhaps is a large gap between the process final publication and marketing authorization, and we're having discussions with NHS England where that might be apparent and what can be done.
Okay, thank you.
Oh, sorry, Jen. And just to echo what Jenna said, Jenna and I have both been working quite closely with companies and system partners, as she's outlined here, on trying to find out the best data that we can. And in addition to that, all of that information is fed to the Innovation Observatory. So the National Institute for Health Research Innovation Observatory is also known as the NERIO up in Newcastle. And we kind of let them know any early intel that we get for them to be able to pass the topics for us to enable them to move quite quickly and swiftly through the topic selection process. But I guess, as with anything, engagement is key from companies as well. So please, if you do know of anything and you have that early indicator internally, then please do get in touch with either Jenna or I, because that really does speed up the conversations and help you and speed up access through the process.
Thank you both. So Lee, there's a question around the manual, really, around what we've published on the processes, and there's a question about whether we'll supplement the manual maybe with other documents published around the process. The question reflects on the manual being quite focused on methods and doesn't perhaps provide enough guidance on some of the key process options such as fast track and so on. So what are your thoughts on that?
Yeah, I think we have focused on creating in the process side the options and the steps that we have available. But I think one of the areas that we weren't able to sort of get into the document before we published it was some diagrams and explanation of the milestones and the timescales and the routes that technologies will follow through these options as well. So we will have that for the final manual. I'll just hold our hand up and say we weren't able to get that in at this draft stage, but it will be. I understand the point that's being put across, but it will be much more explanatory, and hopefully we'll give a lot more clarity in the final manual.
And if anybody's got any ideas or suggestions for how we could do that, it'd be great to see those through in the consultation as well. David, perhaps one just final question for you. Jenna talked about the new process for loss of market exclusivity. Do you want to just give us a quick flavour of what that might look like and why we've implemented that, or why we're proposing to implement it, I should say?
Wow, with 5 minutes. So I'll be brief. The top line is that where the problem we have is that where products lose their marketing exclusivity and the originator product hasn't had a NICE approval, there is no funding mandate in place for those biosimilars to be used if they are cost effective, and no way for us to find out, or for NHS England as the commissioner to find out if they're cost effective. So we were trying to find a solution to that was pragmatic, that reduced costs to all sides. The intention overall is to have a pragmatic, relatively quick process similar to the FTA process, where there's some committee input but not a full committee meeting, so that any decision can come with a mandate. We are just been on a call this morning with the Commercial Medicines Unit at NHS England to think about how we really align with their processes. But yeah, we're looking to make a recommendation based on the original appraisal, but you looking at whether evidence base or pathways changed, or simply whether costs changed. And if cost has changed, is the only thing that's changed significantly as a result of biosimilars or generic products coming, then we may be able to make a recommendation that comes with a funding mandate. We are working out some of the procedural detail behind this at this point in time. I think the other thing to say, one of the key things that came through in the consultation on the biosimilar piece was around the scope, and we've clarified the scope in the consultation document. So we are considering that generic and biosimilar products are included where the originator got negative guidance. We are considering that we may be in a position to review optimised recommendations where there's a biosimilar involved, with the view to potentially widening the original decision. We are not in a position at this point in time to review drugs that haven't had a submission made to NICE, because we just have nothing to work on. So Jen, back to you.
Thank you, David. So we've only got a few minutes left of the webinar. So just to come back to the webinar that we're going to be hosting tomorrow for those of you that want to return to listen, and for maybe colleagues and friends and peers. So we have a webinar that's focused on some of our methods proposals, particularly the modifiers that we're proposing to introduce, and that will be held tomorrow between 2 and 3 p.m. And there's still a chance to register if you haven't done that so far, and the link is there, but you can also find that on our website as well through our consultation webpage. And the final thing just to say as well is thank you for coming today and for listening to the webinar, and for entering your questions as well. They're all really informative. But please do share your views through the consultation. And of course, those views where you might disagree with the proposals, but also if you do agree with proposals, it would also be helpful to see where there is that consensus agreement as well across our stakeholders, if we have it. So thank you very much. Please do go to the website and take a look at the consultation documents. It closes at midnight on the 13th of October. Thank you for your attendance today, and we'll see you soon. Thank you.